this brings me to another point, Katie, if you don't mind telling us, because regorafenib already is used in colorectal cancer and you practice in that arena as well as a GI oncologist, so what are the adverse events that we can expect there?
I'd say in colorectal cancer or also gastrointestinal stromal tumors where we've used regorafenib extensively and has a label indication as well, or guideline indication, I should say. Regorafenib has pretty similar toxicity to sorafenib and other multikinase inhibitors with anti-angiogenic properties. So we do see a sizable proportion of patients with palmar-plantar erythrodysesthesia, or so-called, that's a mouthful, the hand-foot syndrome that we see with this class of drugs. Also hypertension, which is a clear toxicity that needs to be prospectively watched for, make sure patients with going on to regorafenib or sorafenib for that matter have well-controlled blood pressure even before starting the agent is critical. Loose stools and the cumulative sort of fatigue that builds up with TKI, tyrosine kinase inhibitor therapy. So I'd say in general regorafenib is quite similar in my experience. I have seen some patients with GI upset in the colorectal cancer population, but nothing, I guess, too untoward compared to sorafenib and other family members.
Great. And Riyad, so no doubt that the data is fascinating, and we're all kind of happy to see it. It's always good that we have new products and new drugs that are available for patients. The fact that now you have two drugs that kind of improve survival to the extent that we're describing, will this change your mind or views about when and how to move from local to systemic therapy?
Well, there's no doubt that for patients it's a benefit. I think incorporating it in patient management can be complex, and I think maybe this increases the complexity a little bit. The reality is when you look at sort of BCLC staging and how patients flow, they really, to me, they sort of jump around from stage to stage. If you really look at it clearly, they can go from A to C depending on performance status, et cetera, back to B, and then. So I think it's something that we recognize. It's something that we need to learn to manage. But the reality is, these are things that we need to know about. The presence of now regorafenib. Again, I've always been an advocate of sort of adjuvant sorafenib. I don't know what to make yet of regorafenib in that setting. Is it equivalent? Should we be thinking about it as well? And so this is to me the fun part of HCC. It's always a learning opportunity. Very high level clinical trials that are being performed, 1,000-patient studies, randomized overall survival. Lancet in New England and sort of fantastic stuff that's being done. It's always a learning opportunity. For me personally, I have to see where the regorafenib is going to fit in. And we'll see. I don't know that it's always going to be sort of cookie cutter. Sorafenib, progress on local regional therapy, progress, you get sorafenib, progress, you get regorafenib. Ideally, that might be the case. But again, I think as Richard was alluding to earlier, the multidisciplinary nature of how HCC is managed is something of interest. I did want to highlight something that was mentioned earlier, which is the multidisciplinary aspect of managing HCC. One of the fun parts is not just sort of the initial discussion, but one of the management. And so we also, and I think all you guys do as well, but look at follow-up images of patients managed in our HCC clinic. And it's a fun interaction because the imaging can be off, as Katie was mentioning, the flow dynamics, the M-RECIST. An ablation lesion looks different than something managed with sorafenib or Y90 or DEP-TACE. And so I think one thing to highlight for your viewers is that also interpreting the follow-up as a group is a good educational experience for all of us because we sort of learn how to manage these things, and we learn things that we never expected, like the pattern of progression matters. Is it a lung met? Is it an adrenal met? Is it PVT? Is it ECOG? So these are all things that we learn because of sort of the level of interest and the excitement in HCC.
That's fascinating. Actually, just kind of re-describe that. In other words, what we thought simply might be a kind of, first line therapy like sorafenib followed by second line like regorafenib, actually we're adding another layer of complexity over here that Dr. Salem is kind of alluding and eloquently saying, which is really not only we're looking in the vertical sense, but we're looking now in the horizontal sense, which really kind of especially that interaction between the BCLC B and C, and especially with the advent of the regorafenib data, and especially the add-on of the regorafenib after sorafenib, this is going to be something that will be definitely looked into and tested quite extensively. With this said, Richard, back to you. On the study, again, there was one argument, and doctors are very good at arguments, not necessarily substantiated sometimes, but that well, these patients tolerated sorafenib very well. They are really kind of prepped for the regorafenib. So please comment a little bit about the adverse events noted on the study itself, and at the same time, what's your counter argument to kind of this kind of point?
Well, to pick on resource versus any other study, I think is a little unfair, and maybe you're good at making an argument. Every clinical study is done with a select population of patients, right? That's how we establish proof. That's how we generate evidence. And then there's the practice of medicine where you incorporate that data. Important in the study design is patients were required to tolerate sorafenib and progress on sorafenib with very strict criteria of what that meant. Patients had to be on sorafenib for 20 out of the last 28 days and have documented progression. You alluded to the fact that after they progressed, they had to enroll in the study in a certain period of time. And at the end of the day, in reality, about half the patients on the study were tolerating 800 milligrams a day, 400 milligrams twice a day. Whether any of us feel that represents our individual population, that is open to debate, but that is the group of patients who went on to the study. As Katie mentioned, the toxicity in colon cancer and the tolerability seemed much different than the tolerability in the liver cancer field, in the liver cancer study. And part of that is patients were required to tolerate sorafenib, which does have a similar toxicity profile. So right there, maybe that's why patients were on sorafenib for 7 months, then they went on to this drug, and they tolerated it pretty well. The discontinuation rate was not as high as seen in other diseases. With that being said, the clinical activity of the compound, was very similar to actually the frontline data, 3 months improvement in overall survival. So, I think it's important for us to recognize what the phase 3 data represent and then incorporate that into our practice. Does that mean for a patient to go on in your study, patients need to be on sorafenib for 7 months? No. I would say that for patients who are on sorafenib and have radiographic progression, then those are patients who would be candidate for regorafenib. I think an important thing to take away, and it goes to a little bit of what Riyad was saying, and it relates to that, is patients have a window of opportunity to be treated with systemic therapy. And that means frontline. So that means recognizing when, if a patient was on local regional therapy, that they are progressing, so they get an opportunity to get frontline therapy. But the only way they'll get second-line therapy is if they get frontline therapy, and recognizing when frontline therapy has maximized its activity. So ultimately, patients get a chance to get this continuum of sorafenib to regorafenib.